and welcome to our TED Talk. Today, Pamina and I, Rachel, will be discussing yellow fever in Bolivia. So first, take some time to close your eyes and imagine yourself taking a nice, peaceful, leisurely stroll. As you breathe in the fresh outdoor air, a tiny organism lands on your arm. Before you can even catch a glimpse of it or shoo it away, you feel a slight prick sensation. You look at your arm and find not a trace of the mosquito that just bit you. And off it flies. A few days later, that arm begins to itch, and our story begins. Yellow fever is a serious infection transmitted by the flavivirus by the Aedes and Haemococcus mosquitoes. The virus is difficult to diagnose, especially during its early stages. It can be confused with severe malaria, dengue, hemorrhagic fever, leptospirosis, viral hepatitis, especially Venezuelan hemorrhagic fevers, as well as other flavivirus diseases such as the West Nile and Zika viruses, and other diseases such as poisoning. Blood tests can detect yellow fever antibodies produced in response to the infection, and several other techniques are used to identify the virus in blood specimens or liver tissues collected after death. These tests require highly trained laboratory staff and specialized equipment and materials, which unfortunately isn't available to many patients in rural areas and in urban areas throughout countries around the world. As you probably have heard, the liver is a vital organ, working to keep humans healthy, and the body can't function well if it's impaired. Once contracted, the yellow fever virus incubates in the body for 3 to 6 days, followed by an infection that can occur in 1 or 2 phases. Although most healthy people with strong immune systems who are infected with the virus are asymptomatic, meaning they don't show symptoms, there are still reasons to be concerned. The first acute phase usually causes moderate symptoms to appear: fever, chills, muscle pain, fatigue, backache, headache, nausea, vomiting. Most patients' conditions improve and their symptoms disappear after 3 to 4 days. However, 15% of patients enter a second, more severe phase within 24 hours of their initial remission from the first phase. High fever returns and several body systems are affected. The patient rapidly develops jaundice, yellow coloring on their skin, in addition to experiencing abdominal pain and more vomiting. Bleeding can also occur from orifices such as the mouth, nose, eyes, and even the stomach. Once this happens, the blood begins to appear in your vomit and feces, and the body goes into shock due to blood loss. Kidney function can deteriorate, and multi-system organ failure begins to set in. Unfortunately, 50%, that is half of patients who enter the toxic phase, the second phase, die within 10 to 14 days of being infected with yellow fever, while the rest recover without significant organ damage. Yellow fever is endemic in more than 40 countries in Africa, and a current epidemic is present in areas of Central and South America, specifically in Brazil, Colombia, Ecuador, Peru, and Bolivia. The Pan American Health Organization, PAHO, a branch of the World Health Organization, WHO, have both been working diligently to track the epidemic. However, collecting data, which is what they've been doing recently, is not an intervention. It only measures the magnitude of the epidemic. And so far, since the epidemic has just begun, not a lot of data is out there. But as of late December 2016, 1,401 suspected cases of yellow fever were reported in Brazil, and the epidemic is beginning to appear in Bolivia. Also, infected travelers from infected areas may export the virus if their new surroundings has mosquito species able to transmit it, such as the Aedes aegypti and specific climate conditions and the animal reservoir needed to maintain it, which is the mosquito and their wet environment. In order to prevent more yellow fever cases from developing and to help decrease the current mortality rates, which are extremely high, Bolivians must work together to carry out successful interventions aimed at both people living in rural and urban communities. In the past, many yellow fever eradication campaigns have mimicked the bug-based approach used to deal with other global diseases, such as malaria, which mainly target epidemics with mosquito eradication efforts, but a different approach should be taken with this disease, since there is a vaccine. Mosquito control can also help to prevent yellow fever and is vital in situations where vaccination coverage is low or the vaccine is not immediately available, especially in those rural areas. But mosquito control, as of now, includes eliminating sites where mosquitoes can breed and killing adult mosquitoes who lay larvae by using insecticides in areas with high mosquito density. Community involvement through activities such as cleaning household drains and covering water containers where mosquitoes can breed is a very important and effective way to control mosquitoes and standing water in an environment. But it does disrupt the ecosystem that the mosquitoes live in. In this case, eliminating standing water and providing mosquito nets should come secondary to vaccine distribution. Vaccinated humans are stronger than the disease, especially in rural areas where the insects thrive. Vaccinating humans has a less detrimental effect on the ecosystem than spraying insecticides and wiping out a population of organisms. From a biological perspective, vaccines preserve the biodiversity of our fragile Earth. And unfortunately, pregnant women and newborn babies are unable to receive the vaccine. They make up the vulnerable population. A recent intervention was implemented to promote vaccination. The 2017 World Health Organization's #GetVax 15th Annual Vaccination Week, just last week, occurred in the Americas in their campaign. As for Bolivia, 10.8 million people live in the country. La Paz is the capital. 66% of people live in cities, urban areas, and 34% live in rural areas. 34% of the land is used for agriculture, while 52% of the land is forests. Lots of room for mosquitoes. The life expectancy for males is 68 years, while it's 73 in females. Bolivia is one of the least developed countries in Latin America, according to information from the World Health Organization. The World Health Organization also considers Bolivia a lower middle income country, with approximately $4,206 per capita of income, and the literacy rate among the entire population for the country is 96%. The new political constitution of the state, the NPCE, recognizes 36 indigenous and ethnic nations and their corresponding languages. Bolivia's people as a whole, 68% of them are mestizo, 20% are indigenous, 5% are white, 2% are chola, and 1% are black. Most people from the census that reported these statistics showed 44% of respondents claiming they felt to be part of an indigenous group, mainly the Quechua and the Aymara. The official languages of Bolivia are Spanish, 60% of people in Bolivia speak Spanish, and Quechua, 22% of the people speak Quechua, and Aymara, 15% of the population speaks Aymara. Health disparities are extremely prevalent in the country and contribute to the spread of disease, as seen in yellow fever. However, non-communicable diseases attribute to 59% of total fatalities each year. The maternal mortality rate most recently was 206 deaths per 100,000 live births, and the infant mortality rate is 37 deaths per 1,000 live births. Health expenditure per capita is $427, with 6.3% of the GDP spent on healthcare. Bolivia's healthcare system is unique, where its public healthcare system is mostly operated by the Ministry of Health, the MOH, which regulates and executes the national policies at the central level, but at the regional level, it's a bit different, and it's more responsible for administering resources such as vaccines and medical supplies. More at a local level, the government is in charge of helping to regulate the healthcare facilities and provide healthcare services to more rural populations. But as a whole, the number of people who are covered under the healthcare system is only around 30%. Social Security is also important, and the SBSIO is working to reimburse the traditional healers in their communities for their jobs and the services they provide to people in the indigenous populations, as well as compensate them for the medicine and plants they are distributing.
The Aymara and Quechua are indigenous people in South America. They're estimated to be 3.6 million in Bolivia and make up the largest minority group in Bolivia. They were part of the Inca Empire before the colonization. In 15th and 16th century, before they did fall under the domination of the Spanish colonizers. Most of them are situated right now in the Alpino High Plain of Andes Mountains in Bolivia. They live along the Titicaca Lake and through the Zaguera River and Lake Pupu. The biggest part of the Aymara and Quechua population live in rural areas and have been moved to cities such as La Paz due to finding work opportunities. Aymara speak respectively Aymara and Quechua language as their first language. These languages have been preserved and passed down through generation and generation from the Inca Empire. However, most of them use Spanish as the official language of Bolivia. Their religion is major Roman Catholic. This and other indigenous belief. Catholicism was introduced during the colonial period and was adopted by both Quechua and Aymara. They attend Catholic masses and celebrate baptism and follow Catholic calendar such as Christian events. However, the Aymara and Quechua also believe in the power of the spirit, which lives in mountain, in the sky, and other natural forces such as lightning. The strongest and most sacred of their deity is Pachamama, the goddess of earth. She has the power to make the soil fertile and ensure a good crop. She is prevalent in many religious festivals and rituals such as the offering of Mother Earth. They also worship Inti, the Father God. He is worshipped for harvest and cure illness. Another important god within the Aymara and Quechua culture is Ikiko, the god of luck. He's usually found in small figurines which are kept into their households. The most significant social problem faced by the Aymara and Quechua stem from the colonial times. European colonizers and their descent have treated Aymara and Quechua insignificantly and has taken up their land, returning and resources, returning nothing. The decreased living standards among the Aymara and Quechua and anger between groups has weakened the social structure of the region. Only in the second half of the 20th century has the Bolivian society been open to accepting Aymara and Quechua heritage. In 1952, almost 500 years after the European arrived, was when the Aymara and Quechua and other indigenous groups in Bolivia were given civil rights that other Bolivian people have had for years. This has greatly hindered and affected their progress and development. With access to education, the Aymara have begun to participate in more fully modern lives in the country. They are still, however, having issues with serious class issues and racial barriers. However, unfortunately, many Aymara and Quechua remain in poverty areas and in rural areas. Large number of them moved to cities where life became even more harder. The living condition of Aymara and Quechua depends mainly on where they live and how much they have adapted to the modern life. Some Aymara and Quechua reside in cities and live in modern houses and apartments, and there is a large number of Aymara and Quechua who lives in cities and usually in a single room. This can be very hard when you have a big family with many children. In rural areas, the construction of Aymara and Quechua house depends upon the location and availability of materials. A typical Aymara and Quechua house is a small house made of adobe. Adobe has its advantage because it is highly durable, it is free and widely available. Also, adobe can be found all year long because of the rich ideal soil. Traditionally, roofs were made from hatched materials. However, now they're more often made with tiles. House building is a communal affair based on the ancient system of labor exchange known as asmita. Asmita is an important aspect of the Aymara and Quechua culture. It is a social obligation to help other family members. The exchange of work and mutual aid play a basic role within that community. Such exchange occurs when work is required and a single family can provide. For example, an Aymara Quechua present might ask help from their neighbors in, for example, building a house, digging an irrigation ditch, or harvesting in the field. In return, he or she is expected to pay back in favor by donating the same amount of days to labor to the neighbor. The central social unit of the Ayamaran Quechua culture is the extended family. Typically, a family will include parents, unmarried children, grandparents, all living into one house. Large families with many as 7 and 8 children are normal. The Ayamaran Quechua are herders and farmers. Work is divided structurally within the family. Children mostly tend to herds while men do plowing and digging. The most sacred task of planting is reserved to women, since only they are acknowledged to have the power to give life. This tradition maintained in reverence of Pachamama, the earth goddess. They get both wool and wood from the herd, llama, alpaca, and sheep. A family may also supplement its grazing herd with cows, frogs, and chicken. The growing tourist trade has increased the demand of luxurious wool and has provided monetary resources which was highly needed. Some Ayamaran Quechua also work as laborers in silver and tin mines. However, this is a very hard thing to do because of the hard working conditions, but also the lack of healthcare access in the region in case of injuries. Ayamaran Quechua have mobilized themselves into political and the activist sphere to fight for their rights. They have founded a political party called Catarista. They have elected senators and representatives in the Bolivian government. The most well-known is Evo Morales, which was the first indigenous president of Bolivia. He has fought to create more programs to promote the lives of indigenous community, especially his own, the Ayamara. Some of these programs is the Seguro Básico de Salud, abbreviated SBS, which provide basic healthcare insurance to the indigenous and native people. We're going to talk about the pain-free model using the culture and beliefs that you can see within both Ayamara and Quechua population. As you can see, let's start with the positive perception. The Ayamara have the concept of sumakamama, also called sumak kawawa in Quechua language. This is the concept of living well. Ayamara and Quechua people believe that while you are on earth, one has to live well and in respect of nature and also human life. This is perceived especially in case of sicknesses. The entire community come together to figure out a way to help the patient get better. Sickness is a construct to living in harmony with everything. They believe diseases are imbalance of human to life and the well-being notion. So Ayamara and Quechua people will come together and work in pursuit for medicine and healing. As you can see, there is also the part of negative perception. One of the negative perception within the Ayamara and Quechua culture is the coca plant. The coca plant is an important part of the Ayamara and Quechua culture. They use it as part of medicine, but also as offering to gods. The over-reliance to coca as a remedy for everything is, however, detrimental. The Ayamara and Quechua believe coca to be a holy plant, but also a remedy to all sickness. The coca plant has cocaine as its basis. The overconsumption of this plant and self-medication usually hinders their willingness to go to the hospital and become in the long run problematic. One of the biggest issues of the coca plant and might be like nausea, vomit, and addiction. In the existential part of their culture, many people in the Ayamara Quechua community believe in the concept of susto. Susto is the fear of diseases. Some believe are around mal-ojo or info eye. This plays a big role in the fight against diseases and the need for solution when facing adversity. In the part of positive and neutral, there is the carnival, the oruro, other religious rituals. Originally, the indigenous festival was a celebration which was transformed later to blend the worship of both the Virgin Mary, which is part of the Catholic religion, and Pachamama, the earth goddess. This is an important place of meeting to many indigenous communities, including Ayamara and Quechua, and it's an opportunity to exchange information, especially around health issues and other issues faced by the community. There is also Satiris or Curandero, which are the names for traditional healers within the Ayamara and Quechua tribes. Traditional healers are important people in the Ayamara and Quechua community. They use plant medicine to help those who are sick. Healers reported 181 medicinal plants, which are used to treat 67 different health conditions, ranging from sickness such as fever and body pain, to more specific conditions such as pneumonia, bilonio, and bilonio colic. These healers go through training with local non-profit organizations. One example is VPD, to combine both Western culture and Western medicine to their traditional medicine. They play a big role in helping the community since there's a huge lack of healthcare access in rural Aymara and Quechua communities. On the part of negative enablers, there is the colonial legacy and current government. They play a big role in hindering the health system within this community. The colonial government greatly discriminated against the Aymara and Quechua people. This led to isolation to many people of the part of these communities. The government of Bolivia also does not provide many resources for this population. This could be seen especially in cases of lack of infrastructure or even healthcare access. This has created a big problem and a lot of mistrust and tensions between both sides. In the case of positive nurturers, there is the concept of iyo. Iyo is translated reciprocity or interdependence. It is some ways the opposite. It is some way translated as the opposite of individuality. Aymara and Quechua consider this as a concept of community. However, it's more than community because they consider everyone to be part of family. It implies an intimate long-term relationship between the people within their family and the community as a whole. Inside the iyo, there is a family relation, solidarity, but also relations between people and nature. While someone may move away from the community, they never leave the iyo. This plays a big part of their within their relationship, but also helps when people are sick. The elders of the community use their wisdom to care for the sick, but also the entire community. The people who are sick have strong social network to help them. Another positive nurture is the position of women in society. Women are considered as givers of life. They are nurturers. The respect given to Chimamanda, the earth goddess, is also translated to women in Aymara and Quechua tribes. They care for the sick and the family in general. Women have a prominent position in society, which is helpful in case of diseases such as yellow fever. The negative nurture is migration. A lot of Aymara and Quechua move to cities such as La Paz for work. Those weaken social network and family structure within their community, and many are left behind with the role to individually support the whole family, which is hard, and it's even harder when it comes to sicknesses and diseases. Here are the few oversights that have been made in the implementation of intervention in Bolivia. The government has done so much, especially when it comes to the healthcare. Some of the few things that you will see is the curbing of yellow fever when, for example, there was an outbreak in Eastern Bolivia Welfare Sanctuary where there was death of few monkeys. Also, a few programs that you will see is the extension of their health services from the health services provided to the entire country to be more strategically helpful to the entire native community. Some, however, cultural oversight that you will see were some of the government organizations that do not recognize indigenous groups. The National Health Information System added ethnic-related variables to clinical forms only in 2010. Variables like language spoken, mother tongue, culture, self-identification were not recognized in the healthcare system. This led to medical resources to be given to the general population without considering the most vulnerable populations such as the Aymara and Quechua. This greatly hindered their development and access to healthcare to many indigenous groups. Another problem is the loophole in the health system. Healthcare in Bolivia has covered through major components: the government, the private sector, and the international non-profit organization. The government, through the Ministry of Health, provide public health care. However, it is overwhelmingly burdened because it's only covers 30% of the population. The private sector only covers citizens with formal work and social security. This is done only for those who can afford to work. The international community covers for the rest of the marginalized community. This is done through organizations such as Catholic affiliated organization. However, the problem is only 80% of the entire Bolivian society are part of the formal sector, and also 100% in the rural areas do not do formal work, so which leaves a lot of communities such as Aymara and get cured without no health care. There's also loophole in the vaccination system. In a study done by Lorenzo Pizzoli to evaluate yellow fever immunization coverage after a national campaign in 2007, it was seen that a lot of these campaigns are done in urban areas where a lot of these marginalized communities do not live. They also use the television and radio as a mode of communication, and a lot of these tribes do not use them as a mode of communication. They also do not take into consideration how people migrate through the entire country. A lot of people did not get vaccine because they say they were out of town, which was seen as not being able to get it, but however, they moved out of town to get work. Also, they use vaccination cards, and a lot of this community cannot read and end up losing them. There were also conflicts with the government because of the coca plant. The coca is chewed as a traditional medicine in many of the Aymara and Quechua tribes. However, the government consider it as a drug due to its cocaine basis, and this conflicted because of drug raids that have been made in many of these communities.
So based on the Penn 3 model we just reviewed, developing a successful intervention would mean working with the culture, which would involve collaborating with the Satiris and Curandero. Both are well-respected people who have medical backgrounds and are trusted by their community members. To further expand on this, the program would work collaboratively with the indigenous culture to invest in infrastructure and development, specifically promoting health. Another aspect of the intervention we are proposing is taking an educational approach regarding the importance of vaccination and teaching people how to utilize effective mosquito control methods, specifically for people who migrate to cities for work, so they can share their ideas with the rest of the people back home. Utilizing already existing cultural practices as opportunities to provide health educational programs is key in our intervention. Since everyone comes together during ritual ceremonies or gatherings, taking advantage of these events is extremely important. In the future, the annual Carnival Festival can be an excellent gateway to distribute not only health information on yellow fever and other diseases, but vaccines as well. Our target vulnerable population is also present here, that is, mothers and children, who can be educated on how to prevent the disease since they are unable to get the vaccine. Educating the elders as well is extremely beneficial because they too have the respect of people in the community.